neurology, physiology, and anatomy, the hypothalamus and the thalamus, along with the limbic system, the cerebellum, the basal ganglia, and the cerebral cortex regions. So essentially in this video, we're just going to cover all of the main regions within the brain, okay? First, we have the hypothalamus. The hypothalamus, as you remember probably from your years of studying before medical school, it's going to maintain homeostasis, okay? So this is the main regulator of the human body. This is what you have to think about, okay? It's going to help send information to our anterior pituitary and our posterior pituitary. It's going to help release hormones. It's just going to regulate the human body, okay? Now, what you need to know is that there's multiple nuclei located within the hypothalamus, and each nuclei has its own specific action, okay? I won't belabor the point, but I'm just going to go through them very quickly and tell you which ones are high yield and which ones you don't have to worry too much about, but still think about. So the lateral nucleus of the hypothalamus is going to be hunger, okay? So lateral nucleus is going to stimulate us to be hungry. The ventromedial nucleus is going to do satiety, okay? So there's multiple, I would say mnemonics that are out there to help you memorize those, but lateral is going to be helping you get hungry and ventromedial helps you be full. So a question that they might ask you is that if you have destruction or if you have a lesion located at the ventromedial nucleus in the hypothalamus, what might happen? Well, yeah, you have no ability to be essentially full. You don't have the feeling of being full, so you will eat continuously, okay? Because you knock out the ventromedial nucleus, which helps with satiety, so you're going to continuously eat because you no longer can achieve satiety, okay? It can be confusing to think about, but you'll get there. It's very easy once you get there. Next is the anterior nucleus, which does the cooling system of our body, and the posterior nucleus, which does the heating system of our body. Relatively straightforward, and once again, there are many mnemonics that are out there, specifically in your books, that tell you which is which. These next two are probably the most important ones of the hypothalamic nuclei. First being suprachiasmatic nucleus, which we discussed, is in our sleep physiology video, but this regulates the circadian rhythm. Okay, the suprachiasmatic nucleus controls our circadian rhythm, which helps control our sleep cycle. You have to remember that. The one and most important one besides suprachiasmatic nucleus is going to be your supraoptic and paraventricular nuclei. This is going to be in direct talking with the posterior pituitary. We're going to be communicating directly from the hypothalamus to the posterior pituitary via the supraoptic and paraventricular nuclei, because both of them produce two hormones that we really, really need. And the way that I remember this is opas. You know, like when Greeks say opa, but there's multiple Greeks saying multiple opas, so it's opas, okay? So OPAS, O is for oxytocin, and it's produced by paraventricular nuclei, okay? So that's OP. And then A is ADH, which is produced by the supraoptic nuclei, and that's AS, okay? So OPAS, opas, tells you which specific hormone, oxytocin ADH, is produced by which specific nuclei from the hypothalamus, okay? And that is very, very, very high yield. Next is the thalamus. You remember VPL and VPM, as well as the lateral geniculate and the medial geniculate, as well as the ventral anterior and ventral lateral nuclei. I'm not going to belabor this point. Thalamus isn't something that they like to really test much on for nuclei, but remember what the overall point of the thalamus is. It's the major relay system for the central nervous system, okay? And so a stroke in the area, let's think big picture, a stroke in the thalamus can lead to contralateral facial sensory loss, okay? And you might not know this now, or you might know it from M1 year, but whenever you see facial abnormalities, we usually think that the lesion is usually on the same side for the face, okay? But if you see that there's a lesion and you have contralateral facial sensory loss, you know that the lesion is going to be at the thalamus. And that's a key takeaway. That's something that you need to understand, okay? So whenever you have a stroke in the thalamus, it leads to an abnormal contralateral facial sensory loss, which you would not normally see, because usually facial loss is going to be ipsilateral to essentially to your deficit. Okay, so whenever it's contralateral facial issues or facial sensory loss, think about a stroke in the thalamus. All right. Next is going to be our limbic system. Limbic system is going to be like fear. Okay, it's going to be like emotion. Okay, feeding, fighting, just feeling. Okay, all of that is going to be the limbic system. Now, once again, shorten it up, it's the emotion. But what they like to talk about specifically is the dopaminergic pathways that occur within the limbic system. These, although you might not think so, they're very high yield to understand. So let's break them down easily so that you can understand them. The mesocortical pathway, okay? So this is, by the way, let me start off by just saying, this is where all of the dopamine can travel to, okay? There's 4 different pathways that dopamine can travel to within the brain. Here are the 4 different ones. The first one is a mesocortical pathway, okay? Now, what they want you to know about this is that when you have decreased activity in the mesocortical pathway, it leads to negative symptoms, okay? And we'll talk about what negative symptoms and positive symptoms mean, specifically in schizophrenia, but that means that you're going to have negative symptoms, okay, if you have decreased activity in the mesocortical area of the dopaminergic pathway, okay? And the mesolimbic pathway, increased activity in the mesolimbic pathway leads to positive symptoms, okay? Once again, seen in schizophrenia. And this is the primary target of our antipsychotics, is the mesolimbic area, okay? Next is the nigrostriatal area, okay, or pathway. And this is going to be motor control, all right? And this is going to be seen when you have decreased activity of the nigrostriatal area. You can see extrapyramidal symptoms, okay? And that's why it's significantly affected by antipsychotics and in patients with Parkinson's disease. The extrapyramidal symptoms, which we'll cover later on, but it's essentially just abnormal movements, is due to the fact that you have decreased activity in the nigrostriatal pathway. And then last but not least is an easier one. It's the tuberoinfundibular pathway. This is going to connect the hypothalamus to the pituitary. So this is going to help us essentially, if you have increased activity, it leads to decreased prolactin production because dopamine is an antagonist to prolactin. But if you have decreased activity in the tuberoinfundibular pathway, it leads to increased prolactin production. Okay, so it regulates prolactin. All right, so let me just run through that real quick one more time because it's relatively important. If you have decreased activity in the mesocortical area, you get negative symptoms. If you have increased activity in the mesolimbic system, you have positive symptoms. If you have decreased activity in the nigrostriatal area, you have extrapyramidal symptoms. And then if you have the tuberoinfundibular, if you have decreased activity there, you have increased prolactin, okay? The first 3 are going to be dealing with our schizophrenia and a lot of our psych disorders, which we'll talk about in the psych videos. Next is our cerebellum. The cerebellum is going to modulate, once again, balance, the cerebalance, or cerebellum is cerebalance, okay? So this is going to help us coordinate balance. Whenever you see someone saying in a STEM, wide-based gait, okay, you know that they're talking about some type of cerebellar issue, okay? Now, cerebellum also has ipsilateral issues. So when a patient comes in and they say that they have an inability to do certain cerebellar tasks, like one example is dysdiadokinesia. So that's like flipping your hand back and forth, or essentially any fast movement of any muscle. So the reason we do flipping your hand back and forth is because that's just a quick movement of a muscle that we can easily see. So if you have an inability to do that, that's known as dysdiadokinesia, all right? And that's going to be indicative of a cerebellar issue, okay? But that's going to be present on an ipsilateral side, okay? So if I have dysdiadokinesia on my right hand, that tells me that the right side of the cerebellum is messed up. So the key aspect to all of cerebellum is that it will have ipsilateral issues, not contralateral issues, okay? Once again, that wide-based gait can give you a lot of key factors or kind of give you a key hint that they're talking about cerebellum. An acute lesion to the vermis causes truncal and gait ataxia. But when you have lesions to the hemispheres, the outer portion of the cerebellum, it will show up with limb dysmetria. Okay, so keep that in the back of your mind. The closer you are medial on the actual cerebellum, you will have more medial symptoms like truncal and gait ataxia. The further out you are for the lesions to be, like in the hemispheres, then you'll have more distal effects in the human body, like limb dysmetria. Okay, so keep that in the back of your mind for the cerebellum. Next is the basal ganglia. What you really need to know about the basal ganglia is that it helps with voluntary movements and adjusting posture. That's pretty much its main mechanism of action. Now, you have the direct and indirect pathways. The direct pathway is going to help increase motion, and the indirect pathway is going to help decrease motion, okay? And dopamine from the substantia nigra, or the nigrostriatal pathway, is going to help increase motion, okay? Now, I'm not going to go specifically in depth on direct pathway and indirect pathway because I don't think it's relatively high yield or helpful. But what I want you to know overall is that a certain pathology, and we'll talk about it later on, but I think it's useful when I bring it up here, is that whenever you have, for example, lacunar infarcts, okay, and lacunar infarcts are caused by hypertension in patients, and it just means that since you have hypertension, you have an inability to perfuse a certain area within the brain, and the certain area is going to be deep structures, and they cause lacunar infarcts, okay, secondary to hypertension. They can hit the subthalamic nucleus, okay? The subthalamic nuclei, okay, is very, very, very important within the basal ganglia. It helps decrease movement. So if we cause an infarct located near the subthalamic nuclei, it can lead to hemiballism, where half of your body is essentially losing control. You cannot stay still for half of your body, okay? Key to understanding basal ganglia, honestly, the only thing that's important about basal ganglia is this topic, but I'm not going to belabor the direct pathway and indirect pathway points.